Good afternoon, everyone. Thank you so much for joining us for What's New in Addiction Medicine. I am subbing for our usual MC extraordinaire, Paxton Bach, who is currently at home on a snow day with his kids. But today I have the pleasure of introducing Dr. Justin Fernandes, who is going to be presenting to us on managing emerging adulterants and complex withdrawal in an evolving toxic drug supply. Dr. Fernandes is an addiction medicine fellow who trained in family medicine. He completed medical school here at UBC, as well as his family medicine residency in the Surrey South Fraser program. He is currently completing his addiction medicine fellowship, and I have the pleasure of introducing Justin.
Awesome. Thank you so much for the introduction. So I'll jump right into it. First, just want to take a moment to respectfully acknowledge being a humble guest on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. And then, so let's go. These are the kind of learning objectives, slight changes to the ones that were circulated, but basically we'll be examining the impact of adulterants on the unregulated drug supply, explore some strategies for clinical management, and of these adulterants. Okay, so this is a bit of an outline. We'll talk a little bit about the toxic drug crisis, set the context, talk a little bit about the adulterants in the opioid supply, focusing on some of those higher potency opioids, benzodiazepines, and alpha-2 agonists or TRENC. And then we'll switch to some management strategies that we can see. So setting the stage a little bit, this isn't going to be new to most of the people here, but public health emergency was called in BC. As of June 2024, more than 14,500 lives were lost due to, in part, unregulated toxic drugs. We're 8 years now into the public health crisis. We're seeing new higher potency drugs coming into the market. Nitazines, the next step up from fentanyl. We'll talk more about that later. We see these potent sedatives causing mass overdoses. And yeah, just really emphasizing that toxic drugs continue to claim about the lives of 6 people in British Columbia every day. First Nations make up over 3% of the population, but 17.7% of the toxic drug deaths. This was in the first 6 months of 2023. So some populations are being hit disproportionately hard. And fentanyl does continue to be the primary driver in 82% of toxicologic test results, but there's other things creeping up and kind of getting mixed in there as well that we'll talk about. So this was just some of the adulterants. We have really good drug checking services that provide a lot of data. And so this was the November 2024 drug checking in BC data. You'll see there's a bunch of things listed here. There's also this other category with a bunch of stuff on top of that's in smaller amounts, but still there. So we'll just talk about some of these. You've got the fentanyl analogs, heroin, no nitazines in this one, but they do appear every once in a while. They tend to be in pretty small quantities though. And you've got benzodiazepines, kind of weird and wonderful ones that kind of prop up every once in a while. And they tend to change as well. Atizolam used to be pretty popular a couple of years ago, and now we're kind of seeing that less so and more of diazalkylgedazepam, bromomazolam, and some of these other ones. And then you have the TRENC, or the alpha-2 agonists, the veterinary tranquilizers. We'll talk more, but the big ones are xylazine. Xylazine was pretty common a few years ago. Now medetomidine is starting to emerge. It's kind of a more potent version of that. And then just checking in, and I looked at data from Toronto as well. They have some information, and just wanted to highlight that 23% of expected fentanyl samples contain multiple high potency opioids, so more than one. We're seeing benzodiazepines there, and we're seeing veterinary tranquilizers there as well, to a higher degree than in BC even. So let's talk a little bit about the adulterants now. We'll start with high potency opioids. And we'll go back to basics just for a second. This is probably all information that people know, but opioids target 3 distinct receptors: mu, delta, and kappa. Focus on the mu receptor, which is the main target of opioid analgesics, rewarding effects. But we do recognize that we do have, this is a very rudimentary understanding of how this entire system works. And so we have a lot of different functional groups and a lot of different arrangements in activating this receptor system, and they interact in different ways. And so you can see the wide variety of formulations. And so just wanting to emphasize that there's a lot going on here that we don't quite understand, and it's not as simple as mu opioid targets this, and in terms of potency and in terms of all of the rewarding effects and the clinical things we see. So I wanted to take a step back and mention that fentanyl itself is a relatively new thing in the opioid supply. So heroin used to be the main drug in the opioid supply. It was first synthesized in 1987 by Bayer. It was initially marketed as a non-addictive form of morphine, which didn't turn out to be true. So it was banned in the US in 1924, and other countries soon followed. And it was the primary opioid in the drug supply until early 2000. So for the longest time, yeah.
1897 instead of 1987.
Yes, 1897. That was a typo. My apologies. Thank you for the catch. So yes, over 100 years, not over 30 years. Yeah. But getting back to the point, for the longest time, fentanyl used to be the contaminant in the opioid supply. So fentanyl was first synthesized in 1960. Double checking that year, that looks right. By Janssen Pharmaceuticals. At the time, it was known to be 30 to 50 times stronger than heroin, but only described very sporadically in the literature as a cause of opioid overdose. So there's some case reports. This one was from 1988. There were only 16 cases found in Pennsylvania at the time. And so toxic drug supply, it was toxic to the heroin supply. Here's 30 cases described in Maryland in 1992. Here's 112 cases in California, but from 1979 to 1991. And so it was around, but not super common. And then beginning in the 2000s, this is when we kind of saw this rapid surge in fentanyl overdose that was described. So some of these articles, we've already talked about the public health emergency in 2016, but by 2016, we're starting to see nearly half of all opioid deaths in the US have fentanyl involved in them. It's a pretty rapid shift over a short period of time. And then this was a study in Vancouver that described fentanyl detected in 52% of patients prescribed OAT. And so this was March 2018. And so we're seeing this rapid shift, and now fentanyl is sort of taking over. Continues to increase at a very rapid pace. Public health emergency declared April 2016, and it's still ongoing. Fentanyl found in 5% of opioids in 2012 and 31% in 2015. And then in the latest, this is slightly later than this now, but when I was doing this talk, the latest that I found, November 2024, 91% were fentanyl positive of the opioid samples tested. And so it's basically taken over, and now we're seeing adulterants or higher potency things coming in. I just wanted to highlight the fentanyl concentration over time as well. That has also been increasing. So we compare, and this is just year over year analysis. I smoothed out the in-between stuff, but just to highlight from November 2021 to November 2024, we're seeing an increase in the concentration of fentanyl from 11 to 19% almost. And I did want to compare as well to other parts of the country. Looking at this is from Toronto's drug checking data. And their fentanyl concentration is quite a bit lower than ours, which is an interesting point to note. Just when we're thinking about management strategies, BC versus Ontario or other parts of the world, there are differences in the drug supply and that are worth considering even from fentanyl. And so I just put a list together of some of the contaminants and their relative potencies. And I think we've probably familiar with most of these. Heroin, fluorofentanyl, methylfentanyl were kind of fentanyl analogs. Carfentanil has been in the news. It's 100 times as potent as fentanyl. And then these new ones, nitazines, anywhere from 2 times to 20 times as potent as fentanyl. And I highlighted the last one, atometazine, as that was first found in January 2025. So they were still finding new ones. This is Toronto data, by the way, because they listed when all of these first came in. And so I wanted to just show that since 2019, 2020, and even up till 2025, we're finding new things. We're finding new things with different potencies, and the potencies tend to be so varied that it's hard to really develop a sense of what you're expecting, because you could see 100 times potent fentanyl analog. You could see some heroin in there. That's 1/40th as potent. And then I also just highlighted that the urine drug screens are going to show different things depending on what's there. Nowadays, most people who use opioids will have a fentanyl positive urine, but there have been case reports of nitazine only urine drug screens where it was fentanyl negative, and then they had to send it for further testing to find the nitazines. So yeah, lots going on right now, rapidly evolving. And then just a brief talk about nitazines. So they were synthesized in the 1950s, never clinically approved, can be up to 20 times more potent than fentanyl, as we saw in the last table. They're structurally unrelated to fentanyl, and so they're going to be negative on the UDS. And the metabolites can also be active and more potent than the nitazines themselves. So they first started appearing, or they've been talked about in the literature as appearing around 2019 in the supply in Europe, the United States, and Canada. They seem to be a bit more prevalent in the eastern provinces right now, based on what I was able to find, but they are creeping up here as well. And then just a point about how they can be seen on the Fourier transform infrared spectrometry, which is what our BC Drug Checking Services uses when you send it for the analysis. But they often account for less than 5% of the sample, which is actually below the limit of detection. So it's possible that it's more prevalent and we're just not catching it, but it's hard to say. There are nitazine test strips as well that you can buy, but they're pretty expensive right now. And then, of course, they appear negative on the UDS, and so there's already been case reports. I think this was in Europe somewhere, I can't remember, talking about this non-fatal overdose that was fentanyl negative. And so this is just data from the coroner's report in Ontario. So it was Q2 of 2024. So nitazines were involved in 0.9% of opioid toxicity deaths compared to fentanyl analogs. So fentanyl still 83%, it's the main one, but we're seeing more nitazines kind of coming into the supply. So just briefly, and I know this can be challenging to sort of differentiate, but I did want to just go through some of the withdrawal symptoms from the different adulterants here. So these are the more classically defined symptoms. We'll come back to this later, but there is a bit of a syndrome associated with opioids, opioid withdrawal, and the timeline tends to be pretty varied depending on the half-life of the opioid. So from 12 hours if it's shorter acting to up to 30 hours if you have methadone. Next, moving on to the benzodiazepines. So going back to the basics for a second, GABA A agonists, sedative hypnotics. The important point I just wanted to mention was that they're a very heterogeneous group. So their pharmacologic activity is determined by the type of GABA A receptor alpha subunit. There's 6 different subunits. And so there's differences even though they all hit the GABA A receptor, there's still differences in how they interact at the receptor and what type of clinical effects they cause. So it's complex. Introduced in the early 1960s, they were historically prescribed for anxiety, sleep disorders, alcohol withdrawal, seizures. Tend to be less prescribed for anxiety nowadays, I think. So noticed as an adulterant in the early 2010s, however, in 2020 onward really began to permeate the drug supply. So just using some BCCSU data, they were detected in 50% of suspected overdose deaths, not just in the supply, but overdose deaths specifically in January 2021, which was more than 3 times higher than the data report only 6 months prior, which is 16%. So they had a pretty rapid increase. They've sort of been in the 2010s, they've been slowly building up, and then kind of a rapid increase in the early 2020s. So it's often described in the literature as designer benzodiazepines, and so there's a lot of them. So you can kind of see when they were being synthesized. Tizolam is up there. They're all just every year, every couple of years, it comes up with a few new ones, and they end up being detected in the drug supply. And then, of course, you have chronic use, which results in tolerance and physical dependence, and then you get concerned about withdrawal seizures. And I just wanted to highlight kind of what I already mentioned, that the percentage of opioid samples testing positive has been increasing. Once again, this is year over year, so it kind of smooths out some of the changes in the middle of the years. I just took a quick look at year over year analysis, but this was in the BC drug checking service, and from a low of 14.6% up to a high of 65% of all opioids had benzos, and it's kind of come down a little bit. And in the last 6 months are similar to that 42% mark. So it's come down a little bit, but still, quite high. Almost 1 in 2 of opioid users will also be using benzodiazepines of some sort. And this was just, I was trying to find information on some of the half-lives and pharmacokinetics of some of these designer benzodiazepines, and it's not well described in the literature. And so I found this article that actually looked at trip reports from internet forums to sort of summarize what the effect was, long, short, intermediate, and what the expected half-life is, the main effect, because they're all slightly different. And so it was an interesting one, trying to find some information on this, because they just come up so quickly and so differently that they don't tend to be characterized very well. Yeah, so you can see quite a wide variety. Like some are short, some are very long reported half-lives, and different effects that people like. The anxiety stuff, the sedation, euphoria for one of them. Yeah. So once again, withdrawal signs and symptoms of benzodiazepines. Just wanted to, these are ones that are typically described in the literature. We're pretty familiar with some of these, and I'll go into them in a bit more detail when I compare and contrast some of these withdrawal signs. The timeline also varies significantly due to the varied half-life. Withdrawal, from what I can gather, tends to peak around day 2 and 3, and then mild symptoms can persist for weeks after cessation. But of course, significant variation depending on what actually is being consumed. And we'll just talk a little bit about these alpha-2 agonists, or TRANK. So xylazine, medetomidine, they're actually veterinary anesthetic drugs. They're not approved for human use. Horse tranquilizers, that's typically how they've been used. And they're not typically available in a urine drug screen, so you need to send for further analysis to really get a sense of if they're even present. Very briefly, they act on alpha-2 receptors, and there's this negative feedback mechanism where you inhibit the release of norepinephrine through a feedback system, and so you're inhibiting the effects of alpha-1, and that leads to sympatholytic. So the alpha-1 leads to, so the negative feedback loop stops the activation of alpha-1 and leads to sympatholytic effects, such as the hypotension, the sedation, the anxiolysis. I think the main point here is just that it's a completely different system that can have similar effects to the other substances that we're seeing. And it's centrally activating as well. Xylazine itself, first reported use dates back to Puerto Rico around 2001. Introduced to continental US in 2006 in a small percentage of heroin overdoses, just about 2%, although detection was low at that time, so hard to say exactly how much if it was there. Philadelphia is believed to be the epicenter of xylazine in North America, so it kind of really took its roots there, and 90% of street opiate samples in 2021 had some xylazine in it, so that's very high. It's definitely not that high here. And then it slowly spread across North America, first found in Canada in 2020, became a bit more prevalent in BC in 2022. So this was a chart, a graph that I took from Drug Checking BC, and it shows that the percentage of xylazine detection in unregulated opioids is actually not that high in BC. So kind of bounces around between 1 to 3%. This was in 2023. This was the only collated data that I could find, but in prior years as well, it hasn't been too off from this. Somewhat stable during 2024 as well. And then I just took a look at Toronto's data as well, and it was closer to 14% in December 2023, but I'd been up to 51% in one of the measured months last year. It varied quite a bit, usually between 40s to 50s. But it was quite a bit higher in the eastern side of North America. And then we'll talk about medetomidine. So it's more potent than xylazine, produces a greater and longer acting sedation than xylazine. Recent addition to the unregulated drug supply. So it first appeared in BC in June 2023, December 2023, and February 2024 in Quebec. And at least that's when it started being picked up. So like within the last year and a half is when we're starting to see medetomidine, this more potent version of xylazine. 86% off medetomidine that has been detected by like Health Canada's drug analysis services came from Ontario. So lots of Ontario prevalence. Eastern province prevalence for this one as well. So I was looking to try and figure out if there's what we can characterize in withdrawal. There really aren't any animal or human models to study chronic xylazine exposure. The symptoms are just not well known. In a 2003 narrative review of xylazine by a group in Philadelphia, patients report irritability, anxiety, restlessness, and dysphoria 6 to 12 hours after last use. It's pretty similar to opioid withdrawal symptoms. A retrospective cohort study reviewed opioid use disorder patients with and without xylazine, and they only found that the xylazine group had higher average blood pressure and were more likely to self-initiate discharge. So I don't know how convincing that is, but no other statistically significant differences were found. So maybe that's interesting by itself. I also looked at dexmedetomidine. There's some data in the pediatric critical care literature about withdrawal syndromes. When you remove dex, when they're on infusions for dex greater than 24 hours, and then you stop it or taper off. They identified tachycardia, hypertension, and agitation. So once again, lots of overlap between other withdrawal syndromes, but maybe something to do with vital signs or could point in that direction. I don't know. So yeah, anxiety, restlessness, tremor, dysphoria, irritability, hypertension, tachycardia. Timeline of withdrawal, 6 to 12 hours. I've lots of question marks here because it's just not well described. So we've got opioids, and this I'll be brief. We've got opioids, we've got benzodiazepines, and we've got xylazine, alpha-2 agonists. And you see there's a lot of overlap. So nausea, vomiting, agitation, restlessness, anxiety, nausea, vomiting, restlessness. So I think the bottom line is that it's quite hard to really determine and differentiate. There's not a lot of literature that sort of differentiates. And so a lot of it is based on clinical experience. And even the clinical experience tends to be pretty non-specific, and you're guessing a lot of times. I did talk to several physicians working at different addictions physicians working in different settings. Some unique withdrawal syndromes emerge. So in the opioid syndrome, you tend to get, the rhinorrhea, the lacrimation, the yawning, the pupil dilation, the goose flesh. Those tend to be very those tend to be a bit more on the opioid side of things. In benzodiazepines, you get the tremor tends to be pretty prevalent. You get the sweating, you get the perceptual disturbances, the hallucinations, and of course, seizure and catatonia tend to be pretty unique to benzos. There wasn't a lot to go on here. I just this is just what was that one case study said. The vital signs changes in agitation could point to a xylazine withdrawal. But I did highlight a few things here that could be interesting for people to consider, but I want to emphasize that none of this is really based in anything aside from clinical opinion, essentially. It continues to be an evolving challenge as to how to manage this. And oftentimes what people have told me is they'll try a challenge of opioids, or they'll try a challenge of benzos. And if that doesn't work, they'll try something else. And they base what they're trying on some of these symptoms, but at the end of the day, there's a lot of clinical gestalt baked into this. Let's talk a little bit about management strategies. We'll start with high potency opioids. So I guess setting the stage historically in the heroin era for over a century, When we've tried to manage it, we've been very cautious when it comes to methadone. We've been very cautious when it comes to up titrating meds for a good reason. But what we're seeing is that we need to be more aggressive to really get on top of the withdrawal. And so that's what the guidelines are sort of changing to. And so historically, start at 30 milligrams or less, titrate up by 10 milligrams every 5 days. It's an outpatient, maybe 3 days in a moderate setting. But in this new era of fentanyl and other opioid analogs, the clinical guidance has become more aggressive. So start higher, start at 40, increase by 10 to 50 milligrams every 3 to 5 days now. And there are now starting to emerge novel ways of doing really more rapid up titrations in an inpatient monitored setting. So this is probably going to be familiar to a lot of people. This is Sukhpreet Clare's article describing what's commonly used in St. Paul's Hospital, where you start the methadone at 40 milligrams, but you add 3 doses of 10 milligram PRN or scheduled doses, and then you can consolidate the dose every 3 days. So on day 1, you start at 40, plus 10, plus 10, plus 10, 70. And so at the end of on the 4th day, you consolidate all those 3, you can still go up and you end up with a 110 milligram dose of methadone by day 4, which is pretty novel. Historically, that's been quite aggressive, but it's becoming very common in this particular setting at least. And there. We're starting to see that described elsewhere in the literature as well. So this was an article from May 2023 talking about starting at 30 and doing 10 milligram daily increases until a 60 milligram dose was reached. This one talks about starting anywhere from 10 to 90 milligram. They didn't really give a sense of what they did to justify that, but they said that this was a retrospective analysis that they did based on what the clinicians in their site have been doing. And the first top study had no adverse outcomes that they noted with the 10 milligram daily increases. The second study noted that maybe 4 out of their 112 patients experienced sedation thought to be due to methadone. And so overall seems that we're able to increase methadone at a higher frequency, but still very, very much based on case reports and what's been done at the time. Not a ton of evidence out there, but it's growing over the last couple of years. And then as an outpatient, we recognize that higher tolerance, we start methadone at higher doses. We do the same thing, 40 milligrams and increase by 15. And I looked at the Medify guidelines in Ontario. They're similar. They tend to still say start at 30 at the starting dose, but tend to be more like aggressive and lenient towards starting at that 30 milligram dose. They also recommend Cadian co-prescribing. So you would do 30 milligrams and you would also prescribe Cadian 200 milligrams. This is more for select patients with known tolerance, with the idea being that as you're titrating up either the methadone or Cadian, you decrease the other one. And this is used commonly in Fraser Health as well, in their rapid access clinics. And so it's a very popular thing that they do there. And then the rapid Cadian titration. So this was one that some of the doctors here are doing at the rapid access clinic. The goal is to get to a dose of 1,000 milligrams of Cadian by day 2. And so this is one where the patient needs to stay in the clinic and be observed throughout the day over the 7 hours that the clinic is open. You start by giving morphine 50 to 100 milligram every hour to a maximum of 500 milligram, about 500 milligram total morphine. You calculate a sedation score 30 minutes after every dose to assess for sedation, and if they're not being sedated or they're under I think it's less than 3, then you keep going. And then if less than 3, so if all morphine dose is tolerated, the total for day 1 is given as a one-time 12-hour dose, and then they get the full combined dose on day 2 as Cadian. So that's it was a case series that was reported. And so this is one of the cases. As you can see, they started with 100, then they gave 150, then 150, then 150 for a total of 550 milligrams. And then they gave 500 of extended release, and then day 2 was 1,000 milligrams. Yeah. And then they had also prescribed some hydromorphone immediate release as part of the risk mitigation, or sorry, the the safer supply protocol guidelines. And so they didn't include those because it was anticipated that that would be replacing some of the fentanyl that they would otherwise be using. And then talked a lot about more rapid up titrations and more aggressive titrations. I think there were some contraindications and cautions noted that I think it's worth talking about as well. So the main thing that they are looking for is like high opioid tolerance. So contraindication would be that there's no evidence of high opioid tolerance. You know, they didn't have persistently high opioid agonist therapy level like in the past from a review of their PharmaNet profiles, for example, the 100 milligrams of methadone or 1,000 milligrams of SROM. So they are looking for things that demonstrate persistently high opioid tolerance that would make them good candidates for this. And then, of course, the renal impairment was also important for Acadian, and then ability to provide an informed consent. But yeah, the precautions were mostly because they're just a bit of a higher risk population, so you need to be a bit more cautious with some of those things as well. Okay. And then buprenorphine, we were finding much more rapid titrations described in the literature. So a classic buprenorphine titration induction, as everyone is aware, you start at 2 milligrams and you increase by 2 milligrams until you've kind of met their opioid needs and they're not in withdrawal anymore. But we're seeing that that's just not an effective dose for the current patient population. And so there's this talk of macrodosing and more aggressive inductions to sublocade as well. So this was a case series posted in Ontario in 2023. And so they described the first case with the cows of 16. They were given 4. The cows actually increased, and so they gave them 8, then 8, then 4 for a total of 20 milligrams. And the next morning they received the 20 milligrams Suboxone and a sublocade immediately. And then a second case, cows of 25, the patient was given 16 to start, and then 8 and 8. And that resolved their withdrawal. And then the next morning, they were given the full 32 milligrams of Suboxone and 300 milligrams of sublocade. And that's seeming to work pretty well. Obviously, where the monograph for sublocade says you have to wait 7 days to be stable on Suboxone, but that in clinical practice doesn't really seem to be necessary anymore given the current population and the current opioid levels that people are using. And this was an interesting article I found just describing some characteristic and treatment patterns in Ontario. So these patterns were from Feb 2020 to March 2022. Okay. So 52% of individuals on, so BUPR is the shortened form for sublocade, buprenorphine extended release. So 52% of individuals on BUPR had a claim for the Suboxone as well after their initiation. And so we're seeing that 300 milligrams of sublocade isn't enough to stabilize someone. And so they may need some extra Suboxone, and 52% seem to need that. 18 or 19% of individuals continue to receive only 300 milligram doses after the second dose, which we're also seeing in Vancouver, clinically at least, more often. And then 29% of those who reduced their dose to 100 had a subsequent dosage increase back to 300. So we're definitely seeing there's signals that whether there's actual clinical benefit or not, there's definitely perceived clinical benefit from the patient and from the providers to increasing or staying at the higher dose. And then this one is interesting. 2.2% occurred with of next dose claims occurred within less than 15 days. So patients were getting their first dose, and then within 15 days they were getting their second dose, and then 13.7 of them were getting them within 25 days. So of course the product monograph says 26 days and over, and we're seeing that we may need to be more aggressive in shortening that timeline for patients potentially. At least that's what's happening. And then we're, I made a slight typo, safer alternatives as well. The fentanyl patch program was introduced over the last few years in BC. And so we're seeing that controlling withdrawal symptoms and cravings becomes increasingly difficult with our standard opioid agonist therapies. And so we're looking at new novel ways of managing this. So safer supply fentanyl patch, it's primarily a harm reduction strategy right now that aims to reduce engagement with the toxic unregulated drug supply through provisions of regulated alternatives of known quality and potency. And so we're seeing that these participants have been typically they're chosen because they're unable to stabilize on our regular opioid agonist therapy. So we've tried methadone, we've tried Kadian, we've tried Suboxone. It's not working. They are on the fentanyl. They get on the fentanyl patch program, and they report a lot of clinical benefits. They report less burdensome. The program itself is less burdensome than OAT because you're able to have less frequent check-ins with the pharmacy for the patch changes. It feels subjectively similar to what they're experiencing in the street supply, and so a lot of patients report some benefit from that. And then we do have some clinical guidance from the BCCSU as well, describing it as a safer supply and guidance on how to titrate it and how to start it and initiate it. And it is covered as a provincial benefit under the provincial prescribed alternatives policy as well. So switching gears a bit, let's go to management strategies for benzodiazepines. I'll start by saying that there's very little literature describing management of benzodiazepine withdrawal from the toxic drug supply. So it's a relatively new phenomenon. So I'll review some clinical guidelines and also supplement with some expert clinical opinion from addictions medicine doctors that I've chatted with at various locations in the lower mainland of BC. So to start, I will say that this was the one paper that I found that does describe unanticipated benzodiazepine withdrawal in the context of an adulterated, unregulated opioid supply. So it was published last month, and just 2 months ago now, in December 2024. So 6 cases were presented. All patients were placed on a CEWA-AR protocol. The benzodiazepine doses ranged from 30 to 150 milligram diazepam equivalent. And 2 patients ended up requiring transfer to hospital, one for a seizure that they experienced in the detox center and another for delirium suspected to be secondary to benzodiazepine withdrawal. And so to clarify, this case series describes patients who were only using the toxic drug supply. They weren't seeking out benzodiazepines by themselves. And so these amount of doses are required for patients with the opioid supply specifically. So clinical guidelines limited in this space. This was the latest that I found from the BCCSU. They put out a clinical bulletin in 2021. I think my understanding is that they are working on a new guideline, but it's not quite out yet. But they kind of just say at this point, if suspected in patients who are not reporting using, consult an expert, basically, at this point. And then this is from Medify, and they also don't have a lot to say. They just say, consider administering some Ativan for stabilization may require admission to an emergency department if you're seeing significant withdrawal. And I also looked at any American sources, the American Society of Addiction Medicine. They're putting out a benzo outpatient taper protocol, but don't really have anything speaking to this particular phenomenon right now. I looked at, this was from the British Association of Psychopharmacology. This was from 2012. And so they had a bunch of guidelines on substance use disorders and with respect to benzodiazepine use disorder specifically. So under this section, management of benzodiazepine dependence in high dose and or illicit drug users. So people seeking out benzos. They made a comment that doses greater than 30 milligram diazepam a day are rarely necessary, which is kind of interesting. So they looked at the literature. They didn't have the best evidence, but so that's why they couched it rarely necessary and may not be needed, that kind of thing. But they were kind of like, this is usually sufficient to prevent benzodiazepine withdrawal symptoms, including withdrawal seizures. Now, I don't know if that's how much relevance that has to our current situation compared to what they were looking at, where the benzodiazepine dependence was probably from known benzos like Valium or Ativan or those kinds of things. But it's an interesting sort of anchor in my head, at least, that I wanted to highlight. And then they also say that maintenance prescribing in illicit drug users cannot be recommended on the basis of existing evidence. And I think from what I've seen and from talking to other experts in the area, most people don't typically prescribe regular maintenance benzodiazepines in the outpatient setting. It's usually in the form of a taper, whether it's a longer one in the outpatient or a short one in the inpatient. So yeah, that's it for the guidelines and the literature. We'll jump into a little bit of expert clinical opinion, because I think this is interesting as well, and it has been rapidly changing, I would say, over the last year or two. So I talked to physicians from withdrawal management centers in BC. So Vancouver Detox, Creekside Withdrawal Management Center, and Road to Recovery. Talked specifically about management of benzo tapers, and the report seemed to indicate that they're pretty common right now. Almost everyone gets one, is what one addictions doctor told me, and they typically range from 4 to 6 days in length. So this does mark a practice change, because I think over the maybe even 2 years ago it was less common. And nowadays, a lot of the doctors are saying, yeah, nowadays I just put them on, because if I miss it and I can't, and then I'm just playing catch up if I miss it, essentially. And there's a lot of concern around that, because there have been a few outcomes now where people have had seizures and have to be transferred, and that's what they're really trying to avoid. So these were some of the examples that were given. Whenever I ask, the answer is usually that they're not really based on anything aside from Gestalt. And so something like diazepam, 10 milligram QID, then 10 TID, then 10 BID, then 10 QHS. They use that one quite frequently in Creekside. The other one that I've heard seen is 10 TID for 2 days, then 10 BID times 2 days, then 10 QHS times 2 days. That one I've seen a bit more in Vancouver coastal sites. And I think, yeah, even if patients are not typically put on a taper, pretty much everyone who's using unregulated opioid supply will be at least placed on a CWA protocol to monitor for withdrawal, because there's just a lot of concern about those withdrawal seizures right now. And I think what was emphasized to me was that where there's expert clinical nursing staff who are very familiar with oversedation versus withdrawal from benzos, there tends to be less risk observed from being aggressive with the benzodiazepine taper. And that's why clinicians tend to prescribe them a little bit more. But there aren't any institutional guidelines, like Creekside doesn't have a specific guideline on benzo tapers, Road to Recovery doesn't. And so they tend to still be very independent clinician decision. And you'll get a lot of variety from different clinicians depending on who you talk to. And like I said, I think there is a guideline coming out from the BCCSU, but I don't know what the timeline is on that. And then I also talked to sought clinical opinion from providers in other settings, so not closely monitored detox settings, so outpatient settings like RAC and inpatient settings like AMCT. And the general consensus seems to be that benzodiazepines are not typically prescribed in these settings. There is a bit of an expectation that patients with a very severe opioid use disorder are not stable on an opioid agonist therapy, but titrating up aggressively in hospital will probably use some of their own supply to some degree. And so there's additional concern that if you were to prescribe a benzo taper, now you're introducing potential harm, whereas in the detox settings, it's much more monitored and much more controlled. And then, of course, there are exceptions to this as well. So, for example, if a patient is certified and they're definitely not able to leave, but they're cut off from their own supply, then you may consider a taper. But I would say overall, the Gestalt was more caution in these settings for AMCT settings for putting someone on taper compared to a detox or closely monitored setting or lock setting. And then I know we don't typically prescribe them outside of RAC, aside from very, very specific clinical settings. But Fraser Health, for example, they say we don't prescribe benzos as a general rule, and then I think some of the other RACs may allow it in some ways, but the general guidance is don't prescribe them in these settings. And then I just wanted to make a note about this idea about prolonged taper. So the classic teaching for someone with benzodiazepine use disorder, chronic benzodiazepine use over years, is that they need a long taper, up to six months to a year is often recommended. And there was concern that when benzos first started appearing regularly, that everyone might need this, but this hasn't been observed clinically. There's no literature out there, but from talking to experts in the field, they're not seeing that there is this need. So a short taper, 4 to 6 days, tends to be okay. But I mean, it's quickly evolving, and so we may see something new emerge in the next little while. But right now, yeah, no prolonged tapers have been really prescribed at this point. There's some theories around that. Potentially, there's just the how irregular it is that you're getting your supply. So some days you may have a lot, some days you may have nothing. And so that irregularity, maybe you're not able to build the tolerance that you would need for a long-term taper. But it's hard to say. And there's nothing really in the literature to talk about it. And then I'll talk briefly about management strategies for alpha-2 agonists as well. Very little evidence in the literature. There's case reports. And then I took a look at the critical care literature as well. So this was the one case report of a patient presenting in Philadelphia, 29-year-old female with opioid use disorder, chronic exposure to xylazine and her opioid supply, presumed to be in xylazine withdrawal. It was a bit unclear from the case report how they differentiated between opioid withdrawal and acute pain and xylazine withdrawal, but she had xylazine in her urine, fentanyl in her urine, and so they treated her. They initially started dexmedetomidine and tizanidine to treat xylazine withdrawal. And then developing worsening symptoms, restlessness, Reiger's dysphoria, thought to be due to the xylazine withdrawal. Tizanidine was discontinued and clonidine was started. They also used phenobarbital to treat some autonomic instability. And then they discharged her home on a clonidine transdermal patch, which I don't see used too much here, and also a Suboxone. It's the only case that has been described as xylazine withdrawal, which is why I bring it up. But I think it's hard to make any judgments or clinical decision-making based on this case, just because the patient was there for over 18 days. She was kind of, everything was thrown at her. And so it was hard to say which medications really helped. They kind of claim that clonidine was the main factor here, but hard to say how much that actually impacted things versus everything else. And then in the critical care literature, there's some cases with dexmedetomidine infusions. Patients became agitated and combative, blood pressure, heart rate elevated after dex was discontinued. So started on oral clonidine taper, 0.2 milligram Q8H, and then slowly tapered off over 6 days. The second case, similar situation, dex infusion for 144 hours, persistent withdrawal symptoms 5 days after the dex was continued, started on clonidine 0.1 Q8H, and then tapered slowly over a couple of days. So clonidine seems to be the winner in the literature. Some health updates. Philadelphia, because it's been so prominent, has put out multiple health updates to xylazine, medetomidine, 2022, 2024. Essentially, they're saying, though, if their opioid withdrawal symptoms are not responsive to typical OUD medications, and they have hypertension, tachycardia, and anxiety, can increase your suspicion for xylazine withdrawal. Treat with alpha-2 adrenergic agonists, clonidine, dex, tizanidine, guanfacine. Clonidine seems to be coming up again. Yeah. Seems to be the modality that I've read about the most. It has a long elimination half-life, so facilitates slower tapering. It has antihypertensive effects observed within 30 to 60 minutes, peaks within 2 to 4 hours. Total daily doses, split TID of 0.3 to 0.9 appear to be effective. It also acts, this was kind of interesting to me, on the locus coeruleus in the brainstem itself to modulate physiologic responses to stress and panic. So it actually decreases your anxiety levels very centrally in the brainstem itself, which I thought was really interesting. I mean, we know it works to manage anxiety. I just thought it was really interesting. Yeah, so kind of a whirlwind of things. We're kind of short on time. So in summary, there's a lot of varied and diverse adulterants in the drug supply. It's very quickly evolving. It changes year by year. Withdrawal can be complex, challenging to differentiate due to the overlapping symptoms. The novel strategies that I've talked about so far tend to be aggressive and due to clinical need, but evidence is really lacking in this space. And there's lots of opportunity here to sort of create new evidence or develop new protocols, especially in controlled detox settings.
Awesome. Thank you. Thank you so much, Dr. Fernandes, for that talk. I'll open the floor. We've got about 5 or so minutes for some questions. Anyone have any questions or clarifications? Yeah. So I'll just repeat the question, was on prescribing gabapentin as a management strategy for benzodiazepine contaminated supply.
I don't know if I specifically looked at gabapentin itself. I know from my experience that gabapentin tends to be pretty good at kind of some of those longer term symptoms that last for longer periods of time. I know there is a bit of hesitancy to prescribe gabapentin too early because you're not really managing the seizure risk as much, which is why a lot of places tend to be aggressive at the benzodiazepines first, just because gabapentin doesn't have seizure protection. So I don't know if I've come across anything specifically in the short term, but definitely in the longer term, gabapentin tends to be prescribed more regularly. I don't have any literature citations for that though at this time. I don't know if you wanted to add anything or.
I think gabapentin itself is better for symptomatic management. I actually was going to ask a similar question. I'm not sure if that's going to come out in the new guidelines that are to be published, but I don't see it very often in the acute setting.
It didn't come up as much in when I was talking to addiction medicine doctors either, in the various detox settings. Definitely as an adjunct though, it's often a PRN.
Any other questions? Yeah, Greg.
Did we, like, when you were looking through all the different contaminants, does dexmedetomidine come up at all as a contaminant? And if so, like, why not compare to medetomidine? It's just a cost thing, do you think?
So the question was on dexmedetomidine and whether that was coming up as frequently as medetomidine.
So I didn't see dex at all yet. I'm not sure. I can hypothesize that like medetomidine is primarily a veterinary tranquilizer, and so it might just potentially be easier to access, easier to synthesize. There's less restrictions around medetomidine than dexmedetomidine because dexmedetomidine is a prescribed medication. That would be my guess. But I think looking at the data from Toronto and on NBC and just doing a literature search, I haven't seen dexmedetomidine in the drug supply yet. So, yeah.
Oh. You know how to access the chat. So just a comment from Dr. Bach, just clarifying that there are no guidelines coming out anytime soon.
Oh, okay. Not too bad.
Though the results of a Delphi study summarizing more general principles should be available relatively soon, along with some sample protocols.
I had heard some rumors.
If anyone wants to get to work on a guideline.
There's a good opportunity here, so.
Any other questions, comments?
I guess, you know, given the timeline, if you look at when benzos were most prominent within our illicit drug supply, it was during the pandemic. And if you look at xylozine's appearance, it was during the pandemic. The pandemic disrupted international trade to a certain extent, as well as disrupting international tourism and travel. So there wasn't as many opportunities for drug trafficking in the way that drug trafficking used to be done. I guess I wonder whether things will continue to settle down. I mean, it's an interesting thing to think about. If drug cartels were running short of supply of their usual illicit drugs and the way that they manufactured, maybe they had to resort to some of these things that we saw appear in the drug supply. And now we're seeing decreases of some of them. It'll be an interesting thing to follow. It's going to be really hard to predict. And of course, you can't get in on the inside and interview them, or else they'll probably kill you. But I find it interesting that this, temporally speaking, could fit with a pandemic effect of the fentanyl epidemic.
Yeah. So just a comment on the pandemic's effect in the economics and the evolution of the drug supply, which may continue to evolve, which I think is a really interesting component too, because one of the main reasons that you shift from fentanyl to other types of analogs that you touched on was related to the economics and how to make a cheaper drug supply. And I wonder, again, with even just in current politics and what's going on, whether that's going to change with the new influence on border security and the fentanyl czar. We'll see. Great. Any other questions, comments? No? Okay. Well, thank you again, Dr. Fernandes, for your talk.